Sorry. So I would like to welcome Professor Waleed Renno, and I would also like to thank him for taking out time from his busy schedule to lecture us about the anatomy of the floor of the oral cavity. I also want to welcome our ISOI President, Dr. Himanshu Mehta, sir. I also want to welcome Dr. V.S. Mohan, sir, who has been the pioneer in initiating the study clubs all over India for ISOI. I would also like to welcome Dr. Stephen Ide, who is the father of Indian corticobasal implantology, Dr. Amit Gupta, who is the honorary secretary of ISOI, and Dr. Rikin Gogri, sir, who is the national head of all study clubs of India. Thank you so much. And I want to acknowledge and thank each one of you for taking out time and attending this webinar. Thank you so much. So now to begin with, Professor Waleed Renno, I had visited him in the Kuwait University when I had gone there to clear my German board of 1 minute. I think there is an echo. Sorry. So yes, I had visited Professor Waleed Renno. That's where I met him in Kuwait, and his knowledge was phenomenal. I was in awe of his knowledge, and that's why I requested him to give us a lecture on the floor of anatomy of the mouth. So something about him, he has a lot on his CV, and I could just write a few points out of it. So he has done his BSc in zoology from the University of Wisconsin-Milwaukee in the year 1982. Then he did his PhD in medical sciences anatomy from the Medical College, Ohio, USA in 1989. Then he did the postdoctoral fellowship from Thomas Jefferson University in research in biochemistry of collagen diseases in the year 1988-89. Then he did the postdoctoral fellowship in neuroscience research, neuroregeneration from the University of Colorado in 1989-90. Then he did his postdoctoral fellowship in neuroscience research in the mechanism of pain from the University of Minnesota in 1919 to 1993. Then he became the assistant professor in King South University from the year 1994 to 99. Then he moved to the Kuwait University and he became an assistant professor there. And now, since the year 2015, he is a professor at the Kuwait University in the field of gross anatomy, neuroanatomy, embryology, medical education, and development. He has conducted many workshops for German Board of Oral Implantology and also for Kuwait medical and dental specialities. So that is something about Professor Waleed Renno. We want to welcome you, sir, and I would request you to start with your presentation. Thank you so much.
Thank you very much, Dr. Priyanka. I appreciate it. And it's really nice to be with you, although we are in Kuwait and you're in India, but it's my privilege and honor to give such a lecture to you all. Thanks a lot, and I hope you'll enjoy it. And if you have any question, we can, either you can interrupt me or you can leave the questions at the end.
Yes. So, thank you.
Give me a hint or raise your hand when the time is over, because I tend to just keep talking until I get the slides. But I will go. I have many points that to cover, but we can stick with the time at this point, and then later on we can inshallah add more to this introductory lecture.
Okay, and may I interrupt you, Professor? Yes. May I make a request to all the participants to start your video, because it is more interactive and it is better for the speaker and all of us, we can interact better in that way. So if possible, please start your videos. Thank you so much.
Okay, welcome everybody, and Okay, we will emphasize today on the anatomy of the floor of the oral cavity. However, one cannot really understand this area of the oral cavity without going through the mandible, the basic structures and anatomical points that we have to be familiar with. You can see that, okay, in this figure here, the upper figure, that the mandible consists it's a largest and strongest facial bone, and associated, of course, with the base of the skull at the TMG joint. Okay, here, and this is the part of the ramus, which is part of the mandible, and this is the body. So you can see that really it consists of like a U-shaped bone forming the skeleton of the lower jaw. The upper jaw is mainly the maxilla, which is not represented in this figure. It's a horseshoe shape when viewed from the superior aspect. You can see it also here as well in the lower figure, and consists of two parts: the body delineated here, as well in this real bone, as well you can see it here, okay, and the two rami, left and right rami, of course associated with the left and right TMG joint. And the ramus has, as you can see here, and the articulating process forming the mandibular condyle here, okay, with the head and neck, again here, head and neck, and anteriorly a process that projects anteriorly is the coronoid process, and the coronoid process, as you know, which is mainly the attachment of the temporalis muscle that's coming from the temporal fossa on the skull and attached to the coronoid process, and also anterior aspect of the ramus of the mandible. Also, we can see that the condylar process separated from the coronoid process by the mandibular notch, okay, which allows also a certain structures to pass from inside, which is related to the infratemporal fossa, and the outside. Okay. Also, the point where the ramus is attached to the body of the mandible is where we can palpate and see, which is called the angle of the mandible. The angle of the mandible. On the condyle, you can see the articular surface. This is the anterior view. This is the neck, and of course, the neck is important, okay, a landmark for the maxillary artery, which is medial to it. Maxillary, as well as the branching of the external carotid artery. At this point, it will give us the maxillary that goes deeper inward, forming what we call the maxillary artery and the branches, and then continues outward and externally, okay, to form the what we call the superficial temporal artery, and we will see that in other figures. Okay, so it's articulated surface of the condyle is strongly convex, as you can see in the anterior posterior direction, and slightly convex and medio laterally. Of course, you know, if we have the time later on, this TMG is area or joint is a lecture by itself. Okay. Of course, the body, which has the alveolar processes, as you can see, okay, that will house or contain the mandibular teeth, starting anteriorly, going all the posteriorly, and I'm sure you are more familiar with the teeth than me. Okay, the rami and the body posteriorly, they form the angle, and inferior to the second premolar tooth, almost like here, we also find the mental foramen. And this mental foramen, we'll see that it's really an exit for the mandibular canal that is housed within the ramus and the body. Okay, we'll see it from inside as you see it here. Okay, now from this is like a medial inner view of the ramus of the mandible. This is the coronoid process, the mandibular notch, and the condyle. And you can see here the opening of a foramen, or a hole is the mandibular foramen. That mandibular foramen leads to a canal. It's called the mandibular canal within the lower part of the ramus, and then continues in the body of the ramus until it ends with the mental foramen. Okay, it's also overhang over that mandibular foramen is the lingula, which is like a process, a small lingula means like a small tongue overhanging the mandibular foramen, and this foramen will allow the inferior alveolar nerve and vessels to pass through. Of course, the inferior alveolar nerve, a branch of the mandibular, it's a sensory branch, okay? And as it goes down through the mandibular canal, it will give the dental nerves, okay, for each mandibular teeth, okay? And these same nerve and vessels will continue, okay, until they exit through the mental foramen with the same name, mental nerve and mental vessels, but they are continuation of what we call inferior alveolar nerve. This is another view, okay? You can see here running inferior and slightly anteriorly on the internal surface of the mandible from the mandibular foramen is a small also mylohyoid groove. Okay, so this is the lingula, and this is the mandibular foramen, okay, for the inferior alveolar, and this is the mylohyoid groove. Okay, and again here the groove is well depicted. Okay, you can see it clearly, okay, from inside. You need to be familiar with the really inner aspect here of the mandible, and particularly the body of the mandible. Okay, and you can also see a line, okay, that forms what we call the mylohyoid line. Now, what passes through mylohyoid line is a branch from the inferior alveolar, okay, a branch for the inferior alveolar that is given off before the inferior alveolar goes through the mandibular canal, and it goes where downward and medially, okay, to a muscle that is attached here, the mylohyoid muscle. Now remember, the mylohyoid muscle is very important muscle in your approach, in your clinical approach, okay? Why? Because it's going to form the real floor anteriorly, mainly the floor of the mouth, the muscular floor of the oral cavity. So the nerve that is passing in that groove will go to this muscle, and it's called nerve to mylohyoid. Nerve to mylohyoid. Of course, also the vessels, the same, they get the same name. Vessels or artery, that is a branch of the inferior alveolar artery that goes through the mandibular foramen. It has the same name as well. So we call them vessels. It's inferior alveolar nerve and vessels, and then inferior alveolar nerve and vessels as well. Of course, the innervate, remember they innervate two muscles, the mylohyoid muscle and the anterior belly of digastric that is shown in the floor of the digastric, but superficially or from the outside, as we will see. This is the mylohyoid line. This is very important also. Okay, landmark, the attachment. Okay, and also we can see that there is two important landmarks. As you can see from midline here, we can see genial tuberosity in the midline of the body anteriorly, and these called genial tubercles or mental spines. We have superior and inferior. Well, we have variations. You have to be aware of variations. I'll show you some pictures or photos of that. These mental spines or genial tuberosities, they are really attachment points for the muscles that they have the same name, genial, that will give genio, either hyoid inferiorly. So hyoid will go to the hyoid bone in the neck, which form the upper aspect of the neck. So we're talking about this area that goes down, okay, to the hyoid bone. So the name geniohyoid muscle. And this one goes a little bit superiorly and backward, which is the superior genial tubercle, and it goes to the tongue, to the base of the tongue. So we're talking about genioglossus muscle. This is very important muscle also clinically, that you can test the innervation of the innervation of the hypoglossal nerve that innervates all the muscles of mastication of the tongue. Okay, of course, muscles of mastication are all innervated by the mandibular branch of the trigeminal. The muscles, all the muscles of the tongue are innervated by cranial nerve number 11, which is the hypoglossal, except the one muscle, which is the palatoglossus, from the palate side, palatoglossus. Okay, and also we see important depressions that are here. They are seen like one superior, one inferior, but literally you can see here more anteriorly. Here, this is a depression, and this is another depression. And the depression in osteology we call fossa. So here, the anterior superior depression above the mylohyoid line is really lodges or contains the what we call the sublingual gland, which is an important structure that is the one that you need to be aware of it, especially when you have an anterior mandibular approach. So we're talking about sublingual, then fossa, anteriorly and superior to the spine, to the mylohyoid line, and inferiorly and posteriorly. This fossa is called the submandibular fossa. And this also gives you a hint that it's related to another gland, which is the submandibular gland. Okay, so both glands are in close association with the inner aspect of the body of the mandible. And you can see also some variations here with the mental spines. Okay, this is the superior and inferior genial tuberosities. Okay, for the respective muscles I talked about, geniohyoid and here genioglossus. Okay, there's also foramina, sometimes superior mental median lingual foramen, and inferior one. Sometimes these only combined together with one median lingual foramen. Sometimes in this figure, as you can see, there are these spines are really prominent, but that's, in certain cases. Okay, occlusal this is occlusal view of the dry mandible showing prominent bilateral superior genial tuberosity, really big. I have not seen them in my in the specimens that we have in the dissecting room in Kuwait. Okay, and this is really, you should keep in mind this figure all the time. Okay, quickly I will wrap up the mandible. Okay, you can see the coronoid process, the condyle or condylar process with the head and the neck, and the pterygoid fossa is anteriorly placed here, and this is important. Roughly in this region, the pterygoid fossa is the point of attachment of the lateral pterygoid muscle that is occupying, of course, the infratemporal fossa, which is located here. So it attaches to the, remember, to the disc. This is very important, and the capsule, as well as to pterygoid fossa. Here we have the coronoid process. Also attached to that is the temporalis muscle. Okay, we have, of course, the third muscle, also from the inferior of the infratemporal fossa, related to the pterygoid place. Of course, both of them, lateral medial pterygoid, are attached to the lateral pterygoid plate and pterygoid fossa from the skull. And the medial pterygoid is attached here, medially opposite to the angle from inside of the ramus, opposite to the angle of the ramus. Okay. Also, superficially, we have another big muscle that is occupying the whole almost ramus of the mandible and attached strongly to the angle of the mandible, and this is the masseter muscle. Okay, that the four of them, as you can see, that really are attached to the mandible and are the strong muscles of mastications. Okay, working in the TMG joint. Now we have the lingula, the mandibular foramen. Now we are familiar also with this group, mylohyoid group. Okay, this is the anterior border, and this is the oblique line anteriorly. Okay, this is anterior and superficial. And we have the mental foramen here. Also, the mylohyoid line, this fossa is the sublingual fossa, and this is the submandibular fossa. Okay, you can see that clearly also. This is a good example of the angle of the mandible from inside. Okay, the foramen of mandible or mandibular foramen. The lingula here is not that distinguished like what we saw in other examples. Okay, and the mylohyoid line, the fossa here, the submandibular fossa. Okay, here the sublingual fossa more anteriorly. Okay, so when we talk about the floor, the attachment is here. Okay, and separating the superior part, superior anterior, from the inferior posterior aspect of the body of the mandible. Okay, okay, so you need to keep that in mind. So there's a separation here, or the septum, let's call it, okay, between the oral cavity, okay, and below the oral cavity. Of course, what's below the oral cavity or the floor of the oral cavity is here we're talking about the submental area or submental triangle, as we will see it in subsequent slides. And of course, here median lingual foramen and the tuberosities, superior and inferior tuberosities, tubercles or spines. Okay. Now, the oral cavity as a whole, it's a region which is, as you know, part of the head, and it consists of two areas really: the mouth, or the mouth first, then the palate, the tongue, and the submandibular region. Of course, each one needs a lecture by itself, okay, to talk about. But today we'll talk only about the oral region, and we will focus more as we go ahead on the floor here. But let's define it, okay, anatomically. What is when we say oral cavity or the mouth? Okay, it consists of two parts: the vestibule, which is outside between the cheeks and the lips, and the outer aspect of the lower buccal side of the teeth. Okay, including the teeth, of course. Okay, and the oral proper. Okay, or oral cavity proper. Okay, that between the tongue here. Okay, the palate as well seen superiorly, and the floor of the tongue. Okay, of course, the tongue consists of intrinsic and extrinsic muscles, mainly here the intrinsic muscles. These are extrinsic, and there is another extrinsic muscles that are supporting the tongue superiorly and inferiorly. And then outside, really, we get to the submandibular region and the floor of the mouth. Okay, now remember that the mouth is lined by stratified squamous epithelium from you can take also smear from that for chromosomal studies, and temperature in the mouth is about around 37 degrees. It can be used for mouth-to-mouth noise important methods, okay, of artificial respiration. But now, as we mentioned earlier, okay, it consists of vestibule and the oral proper. The vestibule, as we mentioned also, as the cleft between the lips and the cheeks externally, and the gums and the teeth internally. Okay, so we're talking about this here, and we will see it in a different figures as well. Of course, the parotid duct opens in the vestibule of the opposite in the vestibule, opposite upper part of the vestibule, opposite to the upper second molar teeth. Okay, upper second molar teeth. When the teeth are in contact, the vestibule and oral cavity proper communicate only by gaps, okay, that are posterior, last molar, when the teeth are closed. So there is communication when they are closed, okay, these the upper and lower jaws, but it's only posterior to the molar, last molars and ramus of the mandible. Okay, lateral wall, as now here we can see that clearly, the vestibule here, okay, and this is the oral cavity, this is the floor, and this is the tongue, this is the palate, okay, and this is the lateral wall of the oral cavity, which is really lateral wall of the vestibule, okay, of the part of the oral cavity, composed of skin, fascia, superficial fascia. Of course, we don't have deep fascia in the face because this is the buccal region of the face. Okay, so no deep fascia. Remember that, because all the muscles that are seen here, mainly in this view, is the buccinator muscle, are the buccinator and the other facial muscles are all attached to the skin or to the superficial fascia, because they're working on the skin as facial or muscles of the facial expressions. Okay, and we have also the mucosal reflection, okay, that we'll talk about forming the gingiva. The buccinator here and the orbicularis oris anteriorly in this here. Okay, so here the buccal, okay, is here, the buccinator, and the orbicularis oris. These are bilateral muscles of facial expression. As you know, all the muscles of facial expressions are innervated by cranial nerve number 7, the facial nerve. They contract to close the mouth. They are important in mastication, and they prevent this is very important, buccinator muscle and the tongue as well, prevent the food from escaping the teeth and accumulate in the oral vestibule during eating. And of course, all the muscles of mastications are very, very important in sound production, vowel productions and speech. So movements, not only of the food to oropharynx, but also participate in the speech production. Okay, you can hear now, see the vestibule clearly. Okay, now this is the upper part. This is the maxilla, of course, and this is the superior labial gingiva. Okay, the alveolar mucosa is clearly seen. This is labial mucosa over the upper lip. Okay, and the vestibular labial folds. Okay, we have also in the midline what we call labial frenulum, and this sometimes it's so developed that and ties also the upper lip. So a frenulectomy can be performed by even dentists can do that to release the upper lip. Okay, that aids really in speech and movement of the upper lip. And here inferiorly we have the mandible, the mandibular teeth. Okay, the mandibular inferior labial gingiva proper, and then the alveolar mucosa, which is attached, and the labial mucosa over the lower lip. Okay, you can see the upper lip and lower lip clearly here. Oral between them, the opening is called the oral fissure, and mainly surrounded by the orbicularis oris. Okay, and lips, cheeks are the outer surface of the ear, teeth, and the gums. Okay, they also here we have labial, inferior labial frenulum, both upper and lower. This is the upper and this is the lower. Maybe this is, you know, this one, it looks that it requires frenulectomy, which is an outpatient surgical procedure, easily can be done by even dentists. I know that, and clipped and then removed. Here the opening showing from vestibule of the opening for the parotid duct, opening of the parotid duct, which comes from the parotid gland, but that's in the parotid region. That's posterior and lateral aspect of the face. So here we're talking about the parotid even region. Here, as you know, the face has different regions. We have buccal region, parotid region, we have the zygomatic region, we have the nasal region, the oral region, and so the mental region, and so on. Okay. Yeah, this is how. Okay. Now, oral cavity proper is anterior lateral bounded by the alveolar arches. Okay, both arches. That would be anterior and laterally. This is anterior. As you go in this direction would be laterally, but this is of course a coronal section. Okay, as you can see it here at this almost position of the maybe first molar, it seems to me. Okay, posteriorly communicates with the oropharynx. This is the pharynx. Okay, this is the nasopharynx. This is the oropharynx, and this is of course the laryngopharynx. So this part here, okay, opens posteriorly through what we call the facial isthmus. The facial isthmus into the oropharynx, and limited laterally by the palatoglossal glossal arches. Underneath these arches would be the corresponding muscles, palatoglossal muscles. Okay, the anterior arches. They are not seen. I will see them in the floor. Of course, before the floor, the roof here. You can see the roof is the palate. Okay, here is the palate and palatine mucosa covering it, and the floor would be the anterior 2/3 of the tongue, okay, most of it, and this little bit lower sublingual mucosa. That's the one that we are aiming at during surgery, to be aware of the structures underneath the sublingual mucosa. This is another view showing the nasal septum. This is the hard palate, the soft palate. This is the roof of the proper oral proper. Okay, and of course here the oropharynx. Okay, and the fauces. Okay, posterior fauces, oral fauces. Okay, the lower lip, upper lip, and okay, the mandible, and here the sublingual area. Okay, now here we can see, I think, the posterior view of the dorsum of the tongue, as well as the soft palate, uvula, and the anterior and posterior arches, okay, guarding the oral cavity, or separating the oral cavity from the oropharynx posteriorly. And of course, the two arches here anteriorly the palatoglossal arch or fold, and posteriorly the palatopharyngeus arch or fold containing the palatine tonsils, as you can see here. Okay, again, this is the first arch, palatoglossal fold, palatoglossus muscle. Underneath that arch, underneath the mucosa, is the muscle, and also we have palatopharyngeal fold. Okay, this is the blue line, that line. Okay, underneath it we have the palatopharyngeus muscle. Okay, then we have the palatine fossa in between. Okay, for the palatine tonsil, and of course the fauces here, the isthmus of the fauces, and in the midline structure posteriorly and superiorly is the uvula. Okay. Now, in the floor here, okay, we have the inferior surface of the tongue connected to the floor of the mouth, but by a median fold, as you can see here. Okay, this is the frenulum of the tongue, or lingual frenulum. Now remember, lingual, tongue, labial frenulum related to the lip. Okay, so we have superior and inferior lip, as you see here, frenulum of the upper lip, frenulum of the lower lip, okay, or labial frenulum. It's okay. And this is the frenulum, the midline attachment of the inferior surface of the tongue to the floor of the oral cavity. Submandibular duct, also we can see the duct underneath that mucosa. We can follow it from posterior laterally into medial and anteriorly, and it opens in what we call here sublingual papilla, okay, in each side, as you can see here. Of course, the green is the duct that we are seeing here, okay, and the part crossing, of course, these are the lingual, deep lingual vessels and nerve. The nerve is what the whitish one, the vein and the artery, but they are coming from the lingual nerve. Again, lingual nerve, okay, is a branch of the mandibular, and it will mainly innervate the mucosa, the lingual mucosa. They also the floor of the mouth. Okay, it carries sensory innervation for pain, touch, temperature, what have you, as well. Also, it carries the post-sympathetic paraganglionic fibers for the submandibular and sublingual glands, and also lingual glands, okay, under the mucosa, and also it carries an important functional component, which is the special sensation, or special sensory fibers from the anterior third of the tongue, which is the taste fibers. The taste fibers. Are you with me, guys? Is this fine,
Yeah.
Dr. Priyanka? Good. Okay.
Yes,
So,
yes.
good.
But I want to tell you that we have 12 minutes more,
Oh, my, all right.
and if we
Right.
could have more slides only on the floor of the mouth.
Okay, let's see, and then I can let's see that here. Okay, in the floor of the mouth. Okay,
Yes, thank you.
we have the tongue, dorsal surface of the tongue. Okay, and then we have the anterior. And, this is a coronal section. Okay, this is anterior floor under the lateral side. Okay, the main thing to notice is that this is more anterior and this is posterior lateral. Anteriorly, you look at this, the gingiva here covering, okay, of the teeth from inside. Okay, we will see the sublingual gland, the sublingual gland. Okay, as we go posteriorly, okay, toward like the molar teeth, okay, in that area, when you are doing the cutting here in the gingiva or any reflection, okay, you have to be posteriorly more aware of the deep part of the sublingual, submandibular gland. In addition, in the floor medial to that, we see these structures, which are the deep vein, deep vein, deep artery, for deep lingual, deep artery and deep lingual vein, in addition to the branches of the lingual nerve. Okay, let me see. I'll pass these. Okay, again, frenectomy here. Okay, okay. Remember, this is the floor. This is the submandibular here. What are sublingual? What call it? Fold, and the sublingual duct. Okay, underneath that fold, going to the carnicle or the papilla. Okay, and upon here, I'm sure you're familiar. So here in that vicinity, okay, when you are cutting the gingiva, okay, reflecting it, okay, here you have mainly you have to worry about the lingual nerve coming in this direction with the lingual vessels, okay, and then we have the duct here. Of course, there is special relation between the duct and the lingual nerve. Okay, first the lingual nerve, okay, is going to come superficial to that and superior, and then it's going to go under in that way under the duct, as the lingual nerve goes in this direction and the duct goes more anterior to the carnicle. Okay, so this is a peculiar relationship, okay, that needs to be also remembered, okay, in that vicinity. Okay, the arteries that also which are seen, okay, and important is the lingual artery. We're talking about mainly here we have the dorsal lingual. That's more really deep. You cannot see it. It's away from your working area. Okay, and it goes to the palatoglossals and the arch of the tongue in that vicinity. Then we have the deep lingual, this one. Okay, that are that is more medial and also deeper. Okay, the one that you have to worry about in the floor is this one here, the sublingual artery, and it's related also close. You can see it here, okay, and it's coming to sublingual gland. Of course, the sublingual gland, remember, does not have one duct. It has 15 to 20 minute small ductules, okay, that directly release their saliva on the floor of the mouth. Of course, another tonsillar branches that are also deep. Okay, this is also the lingual nerve as it passes. That's a lateral view. So in this view, the mandible has been removed to show you. So really, what they are related, okay, to the medial aspect of the mandible, and this is of course here depicting the deep lingual vein. The vein is darker, of course, than the artery which is next to it, and also branches, maybe the whitish here you can see of the deep lingual branches of the sublingual deep branches of the lingual nerve. Okay. Remember the labial arteries, the superior and inferior, they are coming mainly from the facial artery. And here is showing you which is inside here, the arterial supply of the mandible through the inferior alveolar and also the mental, and also it gives the so I'm gonna go a little bit faster. Just I mean, here the facial artery is really superficial. Okay, it's related to the deep part of the submandibular gland. It's important relation to be aware of. Yeah, yes, but that's superficial. It's not in the vicinity of your cutting. This is the main thing, but you should know, it also gives here submental, okay, submental branch. This submental branch, in some cases, okay, it will go through the mylohyoid muscle, okay, and anastomose with the sublingual, which is coming from the lingual. Okay, so this point anatomically, you need to be aware of the communication between sublingual in the floor here, okay, coming from the lingual artery, and the submental, that is branch of the facial, and it's more superficial, but the good anastomosis through the muscle itself. Okay, these are the orbicularis oris. This is more the facial to show you these the facial branches, and the other, of course, would be that's orbicular, infraorbital blood vessels. This is showing you the superior labile and the inferior labile from also the facial artery. Okay, here where another artery, it's the buccal, a branch of the maxillary. Okay, but that's more also lateral with the buccal nerve, with these okay, branches with the buccal nerve. But these are in the cheek. Okay, because this is a buccal sensory branch of the mandibular, and don't confuse that buccal nerve with the buccal nerve of the facial, which is more superficial over the parotid. Okay, we can say maybe these are branches of the would be even more superficial, because the facial branches would be within the parotid gland, in the middle of the parotid gland, and then it gives the buccal, which is a motor. Yeah, the buccal nerve of the facial nerve is a motor for the facial muscles. While here, the buccal branch of the mandibular is a sensory branch with the buccal artery of the maxillary artery, okay, going in the cheek, within the cheek. And here, I think this is depicting really the course of the inferior alveolar, okay. Remember this, I'm very sure you're familiar with that, okay. The inner aspect, okay, sensory inner aspect of the inferior alveolar, the teeth, and also posterior outer in the vestibule. This is the oral cavity proper. This is the labial side, the inferior alveolar dental
Professor,
branches.
may I interrupt you?
Yes.
There is a comment by Dr. Sham Mahajan. He is requesting for more important anatomical considerations with respect to dental implants in the floor of the mouth.
Okay. Let me move to the.
Thank you.
This is of course, the mucosa that you need to be familiar with. Okay. This is this here, okay, showing you the submandibular. This is from outside the submandibular triangle. That also you need to be familiar with the structures here, mainly occupied. This is the anterior digastric, and the posterior digastric is behind that, and the submandibular. Why I'm mentioning that? Because mainly, you know, this is the floor, okay, and we'll see this is the mylohyoid, okay, muscle that is attached to the muscle, to the name mylohyoid line, from inner aspect of the mandible, and goes posteriorly and inferiorly, as you can see it here as well, to the hyoid bone, which is seen here clearly. This is the anterior digastric or belly of the digastric. Okay, and this is the another muscle, okay, which is more medially placed, okay, and of course goes to the hyoid, and above it, okay, so this is from the genial, inferior genial to tubercle to the hyoid. So this is genuhyoid. Above it will be genuglossus, that is not shown. Now, there is another muscle that is much lateral, and it's called hyoglossus, that attached from the hyoid to the base of the tongue and forms the lateral posterior aspect of the floor. Okay, so here you're cutting here, right? Okay, so this below that, okay, below is which is here, okay, and a little bit deeper is the submandibular gland. And then submandibular gland has two parts. Remember, has the superficial larger part that loops around here, the mylohyoid and posterior end of the mylohyoid muscle and comes this way, comes to a little bit to that region here. Okay, so forming the small part of the gland, and from that gland we have the duct. Okay, let's see here. Okay, this relation. This is the mylohyoid. Okay, so this is the mandible has been cut. Okay, so when you are cutting it through here, the gingiva, the mucocutaneous covering here. Okay, posteriorly, as I mentioned earlier, you have to be concerned about these structures, mainly the lingual nerve, because it's also medial to the second molar, very close to the second molar, almost in that vicinity seen here. Okay, and also the duct that's shown in the green, and of course the vessels, as you can see, the smaller part here of the gland going into an anterior medial direction. Okay, and then as we go anteriorly, okay, you can see the submandibular, sublingual gland, and of course the ducts here, sublingual fold, the ducts. Okay. So these are mainly the relations here that are going to focus. I'm not going to go now through details. We don't have time, but this is a cross section that also remember well. Okay, this is the hypoglossal we are talking about, and this is the mylohyoid muscle, and this is the part that inferior to it. Okay, and related of course to the submandibular fossa. Okay, as we go anteriorly, this is almost like a molar. Okay, the first or second molar coronal section. And you can see the facial artery. Okay, why we mention that during your cutting? Okay, here if you're reflecting the mucosa, you need to think about this coronal section and how the muscles are displaced. And the other arteries, okay, duct arteries are more when you're anterior, like incisors teeth, the canine teeth, the premolar teeth. You're more safe because the duct, the nerve, the vessels are more medially placed, not laterally placed. Okay, this of course this is a slide for really all the relations that we need to worry about. See, as we come here, okay, to this region, okay, the mandible has been removed, but still the vessels are there. Okay, they are more toward the lateral aspect. Okay, as this is the lingual, and these are the vena commentantes of the accompanying the lingual artery. Okay, so and as we go more anterior, okay, and later we see that the structure are going medially toward the base of the tongue, and this is of course the duct. Okay, and this is the nerve that is coming more here from the superior, from of course the infraorbital, from infratemporal fossa, and this
Professor,
submandibular. Yes.
can we see the sublingual artery here?
The what?
Sublingual artery.
Yeah. Of course, this is the here. Let's say this is the dorsal artery, and this is the deep branch that goes to the base of the tongue, and this one here, the sublingual. Okay, that what I want you to be always aware of. That's there mainly if you're talking about the anterior incisor teeth, the canine, the premolar. Okay, with the vein, of course. Okay, and as I mentioned earlier, the submental is here. It's not shown here because it comes from the it's not shown even in this figure, but here it comes from the facial artery, okay, to the submental triangle, okay, under the chin, all right, and also it gives perforating branches and good anastomosis sometimes that need to be also, you need to be aware of. Okay, so this is the submental.
So
Submental.
how
Yes,
that is a sublingual, right?
yes, this one here, see, this
So
one.
how deep it is from the crest of the ridge?
It's really very superficial underneath the mucosa, as it comes from posterior to to anterior. Is going to be underneath the sublingual. Okay, so first you're going to see the sublingual, as you can see it here. See, this is submental. See,
Mhm.
see. So you're safe if you're coming from here, and the second figure to the left here. Okay, if you're going here, okay, you need to worry about the sublingual, okay, gland that is intimately associated with the sublingual fossa of the mandible. Okay, and as you go deeper to that, you will see the veins and the arteries here. Can you see them here?
Yes.
Okay, so yeah, here. So still you're safe. You don't need to go deep. Okay, I know sometimes you have to reflect that and do bone grafting. Okay, you know, you guys you perform different procedures depending. Sometimes from anterior of the chin, you take it from here rather from here. Okay. Yeah, this is a good relation, as we'll see here. Okay, this is the anterior. As we go here, posterior lateral. Okay, see, you're cutting through this part. So here anteriorly, remember the sublingual gland. Okay, the duct is more medial to the gland, more medial to the duct, but superficial. Okay, here it's showing you a good relation of the lingual nerve as it comes from the infratemporal fossa. Here, this is the mandibular branch giving the lingual and giving also the infra or inferior alveolar, and this is the mylohyoid. It goes here underneath that muscle, the mylohyoid muscle. Okay, and this is the little deep small part of the submandibular gland. And see, the relationship is very important here, not only for the last molar teeth in your during extraction or during any work close to that tooth, but also if you're reflecting here posteriorly, you're going to see mainly this one. Okay, the nerve and also the duct and the deep part. That's more posterior, posterior placed. Okay, that's the deep part that's across coronal across here. Okay, so across here. Here it's not shown. Of course, this is more anterior, so it's not shown here. Only the deep part that is going around the mylohyoid, as you can see it here, mylohyoid. Okay. That's more about the relations. Okay, let me show you. Yeah, see here, maybe that's even. Of course, these diagrams they give you just an idea. Okay, but this is what is more, the lingual artery and the lingual nerve. See how close to that second molar and the sublingual here. See, and these are the openings, of course. Okay, so we're talking about in that vicinity here, all right, sublingual gland. So yes, it is anterior lateral, as I mentioned. The duct is here, okay, more posterior, but also posteriorly this part, the submandibular gland, and the blue here is the Wharton's duct or the submandibular duct. Okay, yeah. Here we're showing the sublingual artery and also the submental artery. Okay, and there's variations, as you know, with the arterial blood or more in venous vessels are more variable. Okay, and this is one of the variables that we can see that I told you about that you need to be aware of more anteriorly. Okay, the perforating branches of the submental, perforating branches of the submental. Right? Of course, this is deep. This is in the submental triangle. So it's deep to mylohyoid muscle. This is mylohyoid muscle. And this is the hypoglossal nerve, But that's just, it's not, hopefully you're not perforating the mylohyoid muscle. Okay. Again, okay, these are the coronal sections. Okay. Showing the more sublingual. So we are like almost in the middle. Okay, the canine, it seems to me. Okay, the mylohyoid. Okay, so the structures are mainly medially placed. That we are nerves, vessels, and the duct. Okay, the sublingual gland. Okay. Here, this is dissecting a cadaveric view of the lingual artery, okay, as it comes from, of course, the carotid triangle, okay, and it gives the deep. Of course, the mandible has been removed. Only we see here the mylohyoid muscle, okay. This is the sublingual gland, okay, and this is the glossus muscle. Glossus muscle. This is the anterior of the mandible. Okay? The mental symphysis is here, and this is the sublingual. See, sublingual. The parotid, this sublingual gland has been reflected, by the way. But you can see the arterial branches. Okay, and of course the lingual branch, of course, of the nerve, sublingual nerve. You see here, yeah. Okay, this is the anterior of the ramus, okay, and this is the molar, the third or second molar, okay, and here the gingiva has been reflected. You can see that. You can see the mylohyoid muscle. This is the submandibular gland, see here posteriorly, but of course, this is not the actual dimensions, because things in cadaveric tissue has been reflected and misplaced from its original anatomical position. So the lingual nerve is coming this way, but really it's coming in that direction. The same thing with the sublingual here, submandibular, okay, has been reflected. And this is of course the deep part. And here see, as we go anterior, we have, see, the sublingual. Okay, this is another review. Okay, here the posteriorly, this is the molar. As we come anteriorly, this is the anterior aspect of the mandible, the mylohyoid. Okay, the glands are here, the duct are more deeper. So the only where you have to be careful with is the vessels mainly. Okay, because you don't, all these structures, lingual, okay, or the submandibular are more medial, Of course, sublingual here, remember, sublingual has been reflected. Okay, it's not in that position. This is the, I can stop here. This is showing the perforating branches, by the way, here between the sublingual.
Yes, Professor, it was a very informative lecture. I didn't feel like stopping you. It was like I was really getting.
Sorry about that. I prepared an hour and a half to go into the details of these two glands that are really related to the floor mainly. And yeah.
Yes, so I think we can take the questions. There are a few questions in the chat box, and so Dr. Alankrita is requesting for a second part of this lecture so that we don't miss anything. And by Dr. Neeraj, he is asking if what are the associated spaces and retrieval if the implant slips?
This I really don't know, because I don't,
Yes.
I remember I'm anatomist, so I talk about anatomical structures, okay. But I think maybe we can talk to Dr. Hisham or Dr. Mazen
Yes,
okay,
yes,
about the technical aspect. Definitely. I'm showing you the
yes,
structures and the relations and what you need to be
yes. So,
aware of.
yes,
Yeah.
let's jump on the other question.
Okay.
Which nerve in mandible has the maximum variations?
Nerve of the mandible.
Which
Uh,
has,
yeah. I think, see, even remember some of the variations are rare in the nerves, by the way, but they are there. Okay. For example, take the inferior alveolar. Okay. Sometimes, yes, there is variations, okay, to the different teeth and how it comes out from the mental foramen. And sometimes, okay, you have double canals. Okay. It bifurcates within the canal itself, within the mandible, and it produces two canals within the mandible. Okay, and this is, you have to be careful during implants. Definitely, you have to take care of that. But the X-ray will show you these variations. Okay, in the canal, assuming that if the canal, a second canal is there, or the position or the pathway of that canal is showing abnormality. Oh, yeah, I don't want to say abnormality, but let's say variation. Then you have to put that into consideration when you are planning the depth of the implants.
and the next question is, I think you have somewhat answered it. If you could tell about the variation of the mental foramen.
Mental foramen, it varies, from the well, the height. Let's say if we're talking about yeah, here. Okay, here, okay, you can see, okay, it it could be in any here or area, okay. The distance between the alveolar processes and the mental foramen, this varies a lot. So you have to be careful with that. Even the mandibular canal here, okay, it's not consistent. It varies from individual to individual. So the measurements, okay, need to be taken into precisely, and it's no set. Let's say it's 10 millimeter. It could be 12 millimeters, could be 30 millimeters. It varies, okay, from individual to individual. And sometimes, believe it or not, it varies from one side to another side on the same individual. Okay, so it varies from where, but usually between premolar and second premolar.
One of my patients had two foramens.
See, yeah, this is a rare, okay, but does he or she has what you call canal, do double canals as
No,
well?
no.
Yeah, see, it bifurcates at the end only.
Mm-hmm.
When
Yes.
they, yeah, yeah, but that's good to document, by the way, also.
Okay, I have pictures. I will do that. Thank you. And yes, of course, we have a message from our honorary secretary, Dr. Amit Gupta, that he would like to share about the points that can be considered during the implant placement. With all due respect, sir, you can go ahead. It would be really great to learn from you.
Yes.
Thank you, Dr. Priyanka. Dr. Wahid, it was a wonderful lecture. It was something like revisiting my first year anatomy BDS. Be,
Thanks.
being a maxillofacial surgeon, I have studied anatomy at least 2 to 3 times in my MDS also and my BDS.
Mhm.
This being an implant society, so as per Dr. Shyam Mahajan's question about the applied anatomy, though it will require a lot of time to explain, but a very quick 2 3 points I would like to tell everyone about your sublingual artery, which is coming more anteriorly towards the lingual side of your lower anteriors. If the implants are not directed properly in the proper direction, there is a chance that while creating an osteotomy, you damage that same lingual artery and which causes hemorrhage in the floor of the mouth. So this is a very important thing which we need to. So to avoid that, the best thing is to keep your finger on the lingual side and percuss while drilling, that your osteotomy site or your drill does not perforate the lingual cortical plate on the lingual side of your lower anterior. This is the first thing. Second thing is, whenever you have a resorbed ridge in the second and the first premolar region, where we are tend to say see the mental foramen. We are very enthused to see the mental foramen, and we try to give a deeper incision. In such cases, I have seen that someone there would be a damage to the an extension of the facial artery, which leads to a severe hemorrhage in that area, which needs to be ligated. If not, then it would be quite fatal. Third major point which I would like to emphasize is your submandibular fossa. Again, the direction of your osteotomy or the drill, which goes in the first and the second molar region. If it is not directed more towards the outer side, there is a chance of perforation in the submandibular fossa, which can lead to damage to your submandibular gland and hemorrhage in that area. So this is just a quick point what I wanted to explain, though there are many more. So another major one is the mental loop, which extends 2 millimeters ahead of your mental foramen. So if your implant has to be placed, see to it that you do not uh, create a drill or an osteotomy site very close to the mental foramen. It has to be more than 2 mm away from the mental foramen anteriorly, because you have the mental loop in that area. So you to avoid that loop, you can keep a distance of 2 millimeter ahead of your mental foramen. I think that's enough for today. Maybe some other day we can have a better, more applied anatomy, and definitely Dr. White would be glad enough to tell us more about the maxilla also and the sinus part also.
Hopefully, yeah, in
Thank
the
you so
future.
much,
We'll arrange something
Dr.
like
Amit
this.
Gupta.
Yeah.
Thank you so much for the applied anatomy.
Yeah.
And
Let me just add one point, since it was mentioned about the facial nerve. One has to be really careful also. If this is the facial nerve, I mean artery, where is it? Let's see. Yeah, this is see the facial here and the lower figure and almost the bottom. Okay, you can see that the facial is sometimes the facial and lingual arteries, they are stemming from the external carotid artery as one stem, as a variation as well. You can see that they're coming together and then separating into lingual, which is more deep and medial, and more superficial and lateral is this one, the facial. But the facial, this is the facial. You can see its relation to the inner aspect of of the mandible and the what called the superficial part of the mandibular submandibular gland. It's in fact it's so related or so intimately in contact with the superficial part of the gland. It grooves it laterally and posteriorly. Okay, that means it's related to the submandibular fossa, and that's what you mentioned a minute ago in terms of. Let me show you. Yeah, this here. Okay, can you see that here? See, this is the facial artery. Okay, and the if you perforate and you go to the submandibular, damaging submandibular, that's also a possibility that the facial nerve damage could be there.
thank you, Professor Renno. I think Thank you for the informative lecture. I'm sure that all of us are going to be more confident now, and when we are drilling the mandibles, especially in the lower anterior region. It was a very informative lecture. Thank you so much. And
You're welcome.
I would request our Honorary Secretary, Dr. Amit Gupta, to hand over the certificate of appreciation to you. Um, I think I will have to share my screen. May I request you to stop your screen sharing so that I can start mine?
Yeah, okay.
Okay, I can do that.
Dr. Priyanka,
Yes, sir.
since I'm very much present over here,
Uh-huh.
thank you for having introduced Dr. Waleed Renno on behalf of the ISY Study Club. Dr. Waleed, Professor Dr. Waleed, it's so nice of you to make this kind of a presentation on the request made by Dr. Priyanka. And it was a wonderful presentation, as Dr. Amit, our
Certificate of
secretary of the ISY, very rightly said that the anatomy, I think since he being an oral surgeon, he has done it twice and more extensively as compared to me. I'm an endodontist. But I think very good points raised. And next time, if we could combine it with an applied anatomy, I think that would make wonders to us. And as Dr. Priyanka also said, it's a lot of eye openers for us. At the same time, we not only realize that placing an implant in the lower anterior, mandibular anterior, is easy, but at the same time, it also calls for a lot of caution from our side. It's a tricky area to work with. Sometimes we feel it's one of the easiest places, but it can be very tricky. Anyway, thanks a lot for this wonderful presentation.
You're welcome.
Thank you very much. And on behalf of the Indian Society of Oral Implantology, I really take pride to have you here, and thank you. And thanks, Dr. Priyanka, once again. And Dr. Amit, you can do the honors, please.
Thank you, Dr. Mohan. Dr. Mohan is one of the leading implantologists of India, and I think he is a pioneer into implantology society also. So thank you, Dr. Mohan, for being here with us. And Dr. Waleed, it was a pleasure having you. And on behalf of Indian Society of Oral Implantology, kindly accept our appreciation by our token of a certificate of your wonderful lecture.
Thank you
Thank
very
you
much.
very much.
Thank you.
And we
And
would be happy to have you again with more extensive and more knowledgeable illustrations, which were there, wonderful illustration. Maybe if I would have had anatomy illustrations during my time, I would have scored much better that time.
Hopefully, we'll
well said.
make it up.
Well said. And I think I should not forget, I would also like to thank you on behalf of our president, Dr. Himanshu Mehta, who, for some personal reasons, had to skip the meeting. In fact, till about 8:30, he was going to be attending the meeting. So he just asked me to ensure the fact that I thank you on behalf of him personally and also on behalf of
Thank you. I really appreciate
it. And thanks,
it.
Dr. Priyanka, for this wonderful job.
Thanks.
Thank you. And last but not the least, I would like to thank all the participants for taking out time. Your time was yours and you gave it very generously to us. And thank you so much. And I have one important last announcement. So we have our ISOI Nasik conference coming up on the 23rd and 24th of July in Nasik. And we have wonderful pre-conference courses on the 22nd of July. I think we have around 6 of them. I'm just running them through. You can get in touch with me or any of our ISOI members to get more detailed explanation for the same, and you all can register for it. So yes, thank you so much. Thank you, everyone. Thank you, Professor Renno. Thank you so much.
Thank you, everybody. Thanks for having me, and I really appreciate your suggestions or any inshallah future collaboration.
Thank you. Good night, everyone.
Good night. Good night.
Good night.
Good night, doctor.
Bye bye.
Salam alaikum.
Walaikum salam. Bye bye.